About VRE infections. VRE stands for vancomycin-resistant enterococci. Enterococci are bacteria that are normally present in the bowels of most members of the community. They are also found in the female genital tract and in the environment. 16 different species of enterococci have been recognised, but the one which has given rise to most concern is E. faecium because of its greater antibiotic resistance. In normal circumstances, these bacteria don't cause any health problems, but some of them have become resistant to the antibiotic vancomycin, which was used to treat infections caused by them in the past. This has given rise, of course, to the name VRE, vancomycin-resistant enterococci. Infections from VRE don't seem to be as common in Ireland as other healthcare-acquired infections, but with the outbreak in Sligo General Hospital over the August bank holiday of 2008, this might be about to change. At any rate, more attention may be paid to it. As has been said already, people can sometimes be colonised with enterococci or even VRE without adverse effects, but sometimes these bacteria can and do cause infections. These infections can be of the urinary tract, the abdomen, pelvis, the bloodstream or wounds. VRE has also been implicated in cases of cholangitis, that's inflammation of the bile duct, endocarditis, which is inflammation of the inner lining of the heart, and a type of meningitis. These infections most commonly occur in hospital settings, and enterococci are now said to be the third most common cause of healthcare-acquired infections. As with other healthcare-acquired infections, there are categories of persons who have an increased risk of becoming infected by VRE. And these categories are those who have been treated with the antibiotic vancomycin or other antibiotics for long periods of time. This especially applies to those who are hospitalised. Those with weakened immune systems, with conditions such as cancer, who are in intensive care, or people who are post-transplant. Those who have undergone surgery, especially abdominal or chest surgery. Those who have invasive medical devices, such as urinary catheters or central intravenous catheters. And those who are already colonised with VRE. Most enterococcal infections are confined to the individual patient, but cross-infection between hospitalised patients does occur. It is passed from patient to patient, mostly by the hands of caregivers. VRE can get onto a caregiver's hands after they have been in contact with a person who has an infection, or from contact with a contaminated surface. Individual patients can directly acquire a VRE infection from touching surfaces which are contaminated. VRE is not usually spread by an infected person coughing or sneezing. The recommendations for the prevention of the spread of VRE infections include strict hand hygiene. As with other healthcare-acquired infections, this is of paramount importance. Washing with soap and water is essential when visible dirt is present, and alcohol-based rubs otherwise. This should happen even when gloves are used. The environment should be properly cleaned routinely and decontaminated when an outbreak has occurred. Special attention should be paid to bathrooms and toilet facilities, especially when a patient has diarrhoea. Gloves should be worn if there is a likelihood of coming in contact with body fluid that may contain VRE, and this is blood, stool or bandages from infected wounds. Gloves should be disposed of after each patient and then the caregiver's hands washed. Isolation facilities should be available. Proper controls should be imposed on antibiotic prescription and use, and there should be effective surveillance. There hasn't been as much research done on VRE as there has been on MRSA and C. diff. But as the incidence of infection rises, this will increase also. You can find out more about VRE on the websites www.bmjjournals.com or www.cdc.gov and www.his.org.uk.